Okay, let's unpack this. Welcome to the deep dive. You've shared a really focused set of MSRA revision notes with us today, digging into Clostridia infections,
Mhm.
our mission. To take these notes and turn them into a high-yield review, pulling out the absolute key points you need to know, strictly based on the facts presented here.
That's right. Clostridia are a fascinating group. Some are just environmental bystanders, but others are hugely significant in medicine because of their unique biology. And as these notes underscore, they're incredibly potent toxins.
Right.
We're going to walk through your notes section by section, extracting those essential nuggets for your revision.
Perfect. So jumping straight into the core definition from your notes, what are Clostridia at their fundamental level?
Well, your notes define them as bacteria belonging to the genus Clostridium. They point out there are many species, some harmless, but critically, some are human pathogens.
Okay.
A key feature highlighted is that they are anaerobic. They thrive where there's little to no oxygen.
Right, low oxygen.
They're also described as gram-positive, rod-shaped bacteria, and importantly, they're spore formers, often found in soil.
Ah, spores.
Yeah, their medical punch, according to the notes, comes from these incredibly resistant spores and the powerful exotoxins they produce.
Ah, the spore-forming capability. That's what makes them so tough and pervasive, isn't it? Surviving harsh conditions.
Exactly.
Okay, the notes single out 4 specific species that cause major problems. Let's get acquainted with these key players. Who are the main culprits we need to focus on for revision?
Absolutely. The notes detail 4 main ones you should know. First up, Clostridium perfringens.
Okay.
This one produces something called the alpha toxin. Your notes directly link it to gas gangrene and also hemolysis.
Gas gangrene, right?
Clinically, the notes mention specific features like tender skin, hemorrhagic blebs, and bullae, and that distinctive sign, crepitus, that crackling feeling under the skin.
Crepitus, okay. Heard that one.
Then there's Clostridium botulinum. This name often brings up associations with improperly canned foods and honey, particularly in infants.
Yeah, the honey thing for babies.
Right. It causes flaccid paralysis, and the mechanism your notes highlight is crucial. It works by inhibiting the release of acetylcholine at the neuromuscular junction.
Blocking acetylcholine. Got it. Flaccid paralysis.
Next is Clostridium difficile, often just called C. diff. This is a major player in healthcare settings.
Definitely hear about C. diff a lot.
Yeah, the notes strongly associate it with infections that develop after taking broad-spectrum antibiotics. It causes pseudomembranous colitis and produces 2 main toxins, an exotoxin and a cytotoxin.
Okay. Post-antibiotics. Colitis. 2 toxins.
Finally, Clostridium tetani. This species is responsible for tetanus. Its key weapon, according to your notes, is the tetanospasmin exotoxin.
Tetanospasmin.
And this toxin has the opposite effect to botulinum. It leads to spastic paralysis.
Ah, okay. So C. perfringens with alpha toxin causing tissue damage and gas gangrene. C. botulinum blocking acetylcholine for flaccid paralysis. C. difficile producing gut toxins after antibiotics. And C. tetany with tetanospasmin causing spastic paralysis.
You got it.
That distinction between flaccid and spastic paralysis is a really high-yield point, based on how your notes contrast botulinum and tetany.
Absolutely.
And that mention of crepitus is a classic sign to connect specifically to C. perfringens and gas gangrene.
Exactly. Knowing the unique toxin and the distinct clinical effect, especially the type of paralysis or that specific crepitus, is a powerful memory aid for differentiating the species based on your notes.
Great tips for recall. So we know what they are and who the main players are. Now, where do these bacteria live and how do they actually get into us? Let's dive into the etiology and epidemiology aspects covered in the notes.
Okay, your notes explain they're widespread, found in the environment, with soil being a major reservoir we already touched on.
Right, the soil connection again.
And also in the guts of humans and animals. Entry into the body typically occurs through contaminated wounds or tissue damage by ingest of contaminated food or, relevant for C. difficile, when the normal balance of gut bacteria is disturbed.
Okay, so wounds, food, or messed up gut flora.
Pretty much. The epidemiology varies quite a bit by species, as your notes detail. C. difficile is described as a very common healthcare-associated infection, particularly impacting patients in hospitals and long-term care.
HCAI, yeah.
Makes sense.
C. perfringens is well known for causing foodborne outbreaks, often linked to meat or poultry with a global reach.
Food poisoning connection.
Yeah, and a key point from the notes here is that the heat-resistant spores can survive initial cooking and then germinate and multiply if the food is allowed to cool slowly or stored improperly.
The spores again, surviving cooking. That's tricky.
It is. The notes also mention a rare but serious link to septic abortion involving infection of retained products, though stated as uncommon in the UK now.
Okay, that's noted. Less common now.
And C. tetani, thankfully, is quite rare in developed countries, which your notes directly attribute to successful routine vaccination programs.
The impact of vaccination on C. tetani rates is a crucial public health point highlighted here. That's great.
And thinking about that C. difficile picture, are there specific individuals who are more vulnerable to these infections based on what your notes outline as risk factors?
Yes, the notes list clear risk factors for each species. For C. difficile, the classic scenario often presented in clinical questions involves recent antibiotic use, especially broad-spectrum ones,
The usual suspect.
coupled with hospitalization, advanced age, or a compromised immune system. That combination is a strong signal based on these notes.
Right, that whole picture.
For C. perfringens food poisoning, the notes point towards consuming undercooked meat, poor food hygiene practices, and settings with close living conditions where outbreaks can occur.
Makes sense for foodborne illness.
And for C. tetani, the primary risk factor is contamination of wounds, particularly deep puncture wounds with soil or foreign material.
Dirty ones, basically.
Potentially, yes.
That's incredibly helpful for connecting this information to clinical scenarios. So if you're faced with a question about, say, an elderly patient who developed severe diarrhea after being discharged from hospital on antibiotics, or someone with a dirty gardening wound, these notes suggest Clostridia should jump high up on your list of possibilities.
Exactly. These are the cues to listen for, straight from your notes.
Okay, let's talk about what actually happens once these bacteria are inside. Your notes put a lot of emphasis on toxins. What's the core pathophysiology here?
Right. Your notes explicitly state that the damage caused by Clostridia is primarily due to the potent toxins they produce. These toxins damage host tissues and trigger the various clinical manifestations we see.
So it's toxin-driven.
Mostly, yes. While the exact mechanism differs by species, the theme is toxin action. C. difficile toxins directly damage the epithelial lining of the colon, leading to inflammation and the formation of those characteristic pseudomembranes.
The pseudomembranous colitis.
Correct. C. perfringens toxins cause rapid tissue necrosis and gas formation, seen in gas gangrene.
Necrosis and gas. Nasty.
And C. tetani's tetanospasmin is a neurotoxin that interferes with neurotransmitter release in the nervous system, specifically inhibiting inhibitory signals.
Inhibiting the inhibitors, leading to spasms.
Precisely.
So the high-yield takeaway on pathophysiology from these notes really is, it's all about the toxins. And each toxin has a specific target: the gut, the muscle tissue, or the nerves.
You've nailed it. Understanding that link, which toxin affects which system, is key to understanding the diverse clinical pictures.
Speaking of clinical pictures, what would you actually see in a patient suffering from one of these infections? Your notes cover a range of signs and symptoms.
Well, the clinical presentations are quite varied, depending entirely on the species and the site of infection, as your notes show.
Makes sense.
Common symptoms that might overlap with other conditions include diarrhea, abdominal pain, and fever, particularly with gut infection.
And the non-specific stuff.
But then you have the highly specific signs. For gas gangrene caused by C. perfringens, you'd look for rapid onset of severe pain at the wound site, swelling, foul-smelling discharge.
It's awful.
And critically, the notes list tender skin, hemorrhagic blebs and bullae, and crepitus, that distinctive crackling sensation due to gas in the tissues.
Crepitus, blebs, bullae.
Got it.
Very specific for gas gangrene.
Exactly. For tetanus from C. tetani, the defining features are muscle stiffness and painful spasms.
Lockjaw and spasms.
Yes. Your notes emphasize that the severity can range from mild illness to rapidly life-threatening conditions influenced by the specific Clostridium species and the patient's overall health.
Right. Reiterate those distinctive signs again: crepitus, blebs, bullae for gas gangrene, and muscle stiffness spasms for tetanus. Those are the really high-yield flags from your notes that help narrow down the diagnosis.
Absolutely. They're the key physical exam findings to connect with these specific infections, according to these notes.
Okay, if you suspect one of these clostridial infections, how do you go about confirming it? What does your notes say about investigations?
The notes outline a diagnostic approach combining clinical suspicion, laboratory tests, and sometimes imaging.
The usual triad.
Specific lab tests mentioned include stool tests for C. difficile, which can involve looking for the toxins, or using PCR to identify the bacteria.
Stool for C. diff toxins or PCR.
Okay. For C. perfringens infections, you'd typically take wound swabs or tissue samples for culture and identification.
Swabs or tissue for perfringens.
For C. tetani, serological tests are mentioned as part of the picture, although clinical diagnosis is often paramount.
Tetanus often clinical, but serology helps.
Right. The notes also mention molecular techniques like PCR as useful for accurate species identification across the board.
PCR seems useful generally.
It is. Imaging is also mentioned. Specifically, X-rays or MRI can be used to assess the extent of tissue damage, noting their utility in infections like gas gangrene.
So based on these notes, if you were evaluating a patient with suspected gas gangrene, what specific imaging modalities are highlighted as potentially helpful?
That would be X-rays or MRI to help visualize the tissue damage and, the gas.
Got it. X-ray or MRI for gas gangrene extent? Once a diagnosis is made, what's the approach to managing these infections, according to these notes?
Management is tailored to the specific species and how severe the infection is. The core strategies mentioned involve using antibiotics to kill the bacteria,
Antibiotics, naturally.
surgical debridement to remove infected and dead tissue, especially crucial in gas gangrene,
Debridement for gangrene, yes.
supportive care to manage symptoms and complications, and administering antitoxins where applicable and available, such as for botulism or tetanus.
Antitoxins too, right?
For C. difficile, the notes specify that the choice of antibiotic needs to consider the severity and local resistance patterns.
C. Diff treatment depends on severity and resistance. Makes sense?
Importantly, your notes also stress the role of prevention, particularly in healthcare settings, highlighting strict hand hygiene, implementing isolation protocols for infected patients, and using antibiotics judiciously to minimize the risk of C. difficile infection.
Prevention is key. Hand hygiene, isolation, careful antibiotic use.
Exactly.
So we can think of management in pillars from your notes. Attacking the bacteria with antibiotics, physically cleaning out infected tissue with debridement, counteracting the toxins with antitoxins, providing supportive care, and most importantly, preventing spread and occurrence through hygiene and careful antibiotic use.
That's a great way to structure the management approach described in the notes. Covers all the bases mentioned.
What's the usual outlook for these infections, and what are the potential severe problems or complications listed in your notes?
Well, the prognosis varies significantly depending heavily on the specific species, how widespread the infection is, and how quickly treatment is initiated.
Early treatment is crucial then.
Absolutely. Your notes list several serious potential complications. For C. difficile, while some cases are mild, it can progress to severe pseudomembranous colitis and a life-threatening condition called toxic megacolon.
Toxic megacolon.
That sounds bad.
It is. Gas gangrene from C. perfringens is explicitly noted as life-threatening, requiring rapid intervention and often surgery to improve outcomes. Gas gangrene, life-threatening, requires surgery.
And tetanus from C. tetani, if untreated or severe, can lead to respiratory failure due to persistent muscle spasms affecting breathing and carries a significant risk of death.
Respiratory failure from tetanus spasms, also very serious.
Definitely. The notes strongly emphasize that prompt recognition, appropriate management, and diligently preventing complications are vital for improving patient outcomes.
Makes perfect sense. Given the variety of symptoms, diarrhea, wound infections, muscle issues, how do you tell these apart from other conditions a patient might have? Do the notes mention differential diagnoses?
Yes, your notes acknowledge that the clinical features can sometimes mimic other bacterial or viral infections or different causes of wound infection.
I can see the overlap.
The notes reinforce that differentiating them relies on piecing together the whole clinical picture, the specific signs and symptoms, the results from the lab tests we discussed, and crucially, considering the patient's risk factors.
Putting all the pieces together.
Exactly. It's about integrating all the information from the history, examination, and investigations to pinpoint the specific clostridial culprit or rule out other possibilities.
Okay. Your notes also touched on a couple of specific, perhaps surprising contexts for these bacteria. Tell us about the bioterrorism angle mentioned in relation to botulism.
Ah, yes, this is a striking point from your notes. It highlights the extreme toxicity of the botulinum neurotoxins, stating a lethal dose can be less than 1 microgram.
Less than a microgram. Wow.
Making it one of the most potent biological toxins known. The notes mention bioterrorism scenarios involving the deliberate release of this toxin, either contaminating food or water supplies, or potentially aerosolization.
Scary stuff.
It is. Your notes add that standard water treatment methods can inactivate the toxin, and intact skin acts as a barrier, suggesting the most likely routes for intentional exposure are contaminated food or inhaling aerosolized toxin.
Okay, so food or aerosol are the main biothreat routes mentioned.
That's what the notes indicate.
And you mentioned C. perfringens causing food poisoning earlier. What are the key details your notes provide about that specific type of infection?
Right. Your notes describe this as a common type of foodborne illness. It happens when C. perfringens spores, which survive standard cooking temperatures,
There's a zillion spores again.
germinate and multiply to high numbers if cooked food, especially meat or poultry, is held at warm temperatures for too long or cools down slowly.
The cooling phase is critical.
Yes, often occurs in settings preparing large quantities of food, like schools, hospitals, or catered events. The notes specify that the onset of symptoms is typically quite rapid after eating contaminated food, characterized by crampy abdominal pain and watery diarrhea.
Rapid onset, cramps, diarrhea. Classic food poisoning picture for perfringens.
Exactly.
Okay, we've really conducted a deep dive into your notes on Clostridia infections. We've covered what they are, who the key players are, where they come from, and who's at risk, how they cause disease, what symptoms they produce, how we diagnose and manage them, the potential outcomes and complications, how to differentiate them, and those specific contexts like bioterrorism and food poisoning outbreaks.
We did cover a lot of ground there.
We've pulled out those high-yield facts just as we set out to do.
Thinking back to the beginning, and those incredibly resistant spores mention throughout the notes the fact that they can survive harsh conditions like cooking, drying, or being dormant in soil for years.
Right. It makes you really consider, how does that single characteristic, the ability to form such a resilient structure, fundamentally influence everything else about these bacteria? Their epidemiology, how difficult they are to eradicate from the environment, the specific food handling risks, even the challenges in healthcare settings.
Yeah, it's profound.
It speaks volumes about their survival strategy, something to keep in mind.
Indeed. It's a powerful reminder of the persistence of these microorganisms and why understanding them based on these notes is so important.
That truly wraps up our deep dive into your Clostridia revision notes. We sincerely hope that breaking down these points, highlighting the key facts and connections directly from the material you shared, has made this complex topic feel much more accessible and high yield for your MSRA revision.
Hope it helps.
Thank you so much for providing the source material for this exploration.
Our pleasure. Hopefully this structured walkthrough solidifies those important concepts and helps them stick for your exams.
And if you're preparing for the MSRA and looking for more resources, you might find helpful materials available at pathogenic.com and freemsary.com.
They offer a variety of tools designed to support your studies. Check them out.
Until the next time we embark on a deep dive into a fascinating topic together.
Keep learning and stay curious.